And the mic doesn't work, right? I'm going to take my mask off. Sure.
All right, we're going to go ahead and get started.
All right. Good afternoon.
Morning.
And today's topic is pituitary disorders. It's a very vast topic. So I've tried to concise it as best as I could, but we'll have to discuss topics like SIADH and diabetes insipidus probably at another time. Natasha, I'm not able to move on to the next screen.
Oh, sorry.
Just have to use this. Okay. Is that the next one? Yes. So when you think of a pituitary mass, we need to look to see at three main things. And the first one is if there's a mass over there that's causing symptoms like headaches, visual field disturbances, and so forth. And the second thing we think about is if it is a secretory adenoma, whether there is some kind of hormone production like acromegaly or Cushing's disease or prolactinoma. And the third factor here would be to determine if the person could have any component of hypopituitarism or hormone deficiencies, what exactly is causing the hormone deficiency and how do we treat it? So these are the three important factors that we need to have in mind whenever we think of a pituitary mass. So this picture reflects a normal pituitary MRI. I don't know if you can see my arrow up there. You can, okay. So here is the pituitary gland, and just above it is the pituitary stalk, which connects it to the optic chiasm. And lateral to the pituitary is the cavernous sinus. And this is important to know because of all the nerves that pass through it. And any extension of a pituitary mass laterally can cause nerve defects, which we will talk about later. And again, to the side is the carotid artery over here. And inferiorly is the sphenoid sinus. And sphenoid sinus is where surgeons approach while operating on pituitary. Usual surgeries are done through transsphenoidal approaches. So this is a normal pituitary over here. And this again is a normal pituitary gland. And to the right is a pituitary macroadenoma. You see how huge the tumor is, and it's impinging on the optic chiasm. And such masses usually result in visual field defects. If you remember from physiology, the optic chiasm fibers communicate with the retina, and depending on the area, then you will have a field cut accordingly. And most patients with macroadenomas will have a headache, and this is predominantly the usual presenting symptom in addition to visual field disturbances. And a headache can be of various types, but usually it's a throbbing orbital headache. And it's usually unilateral as well, but we do have other kinds of headache too. So if somebody presents with posterior headache that is diffuse, it's not right to say this does not seem typical for a pituitary headache. So we need to know that it's more commonly orbital or frontal, but it could be of any kind. And the headache occurs because of the expansion of the tumor, and it's pressing upon the dura, and that causes you to have these symptoms. So we'll go on to a case, and I thought that will make it more interesting. So we have a 52-year-old woman who presents with several months of headache, and she has been otherwise healthy and takes no medicines. And her menstrual period stopped at age 44. You examine her and find a left superior temporal visual field cut. Endocrine testing reveals a low free T4, normal TSH, IGF-1 and alpha subunit, LH, FSH, and an appropriate response to cortisol after a Cortrosine stimulation test. The prolactin level is slightly elevated. Normal is anything less than 20 or 22. Hers is 85 nanograms per ml. And a pituitary MRI was done, which shows a 3 centimeter cellular mass with supracellular extension. So what is the next step in management? Replace thyroxine, start cabergoline treatment, repeat prolactin and macroprolactin levels, refer to your neurosurgeon, and perform an insulin tolerance test. Any guesses here? Okay, so you might think that this person has a prolactinoma, but she does not. So this image is a good indicator of how the size of the pituitary tumor influences the prolactin levels. So a microadenoma is any pituitary tumor that's lower than 1 centimeter. And if it's more than 1 centimeter, we call it macroadenomas. So prolactin producing tumors, as the size increases, which we see over here, this is 1 centimeter and this is 10 centimeter. There's an exponential increase in your prolactin levels with increase in size. So if you were to have a person with a 3 centimeter mass, which is quite big, you would expect much higher prolactin levels to the high hundreds or even thousands. So given the size of the mass, it's more likely that this person just has a compression to the pituitary stalk causing prolactin increase. So this is where we need to use our clinical judgment as well. So in smaller tumors, the prolactin levels are lower. So if this person were to have, say, a 5 millimeter cellular mass, then I would think more along the lines of a prolactinoma here. And if you see this option over here, there's something called macroprolactin. So what is macroprolactin? So we do find many tests ordered to check prolactin levels, either for evaluation of infertility or, irregular menses, or sometimes they may be asymptomatic, but they could still have prolactin levels that are elevated on labs with totally no symptoms. And that's when you need to check macroprolactin levels, because there are antibodies which bind to prolactin, and that will falsely elevate the normal prolactin level that we see. But if we do this specific assay, it will isolate that this is a macroprolactin and it's not actually prolactin levels that are increased. So if you know that it's just due to macroprolactin, then the treatment is do nothing. So this is not emphasized enough in primary care practice, because we do get a lot of referrals for very minimally elevated prolactin levels, incidental findings, but the patient is asymptomatic. So all you need to do is check a macroprolactin, see what it is, and then take it forward. Of course, if they have symptoms, you do have to investigate more. So this shows the presentation of prolactinoma in both males and females. As we see in females, the age at presentation is lower. It's around 39 years, whereas in males, it's 45 years. And this is a tumor that's predominantly seen in younger population than in older people because of the clinical symptoms and presentation too. And the prevalence of macroadenoma is much lower, around 44% in females compared to males, which is 85%. And this is, again, probably attributed to the symptoms and how it presents clinically, and people bring it to medical attention sooner rather than later, because it can be quite dramatic in females presenting with galactorrhea and amenorrhea, irregular menses, and commonly seen or diagnosed during evaluation for infertility. Whereas symptoms in males can be more subtle, like hypogonadism, low libido, erectile dysfunction, gynecomastia, and infertility. So with prolactinomas, we also worry in the long term about low bone density or osteoporosis, because your sex steroids go down in this process, and that can negatively impair your bone health. And you also present with visual disturbances if it's a macroadenoma, headaches, and delay in puberty in younger individuals. So to summarize the presentation, this is the most common pituitary tumor, approximately 30 to 40%. And in women, more tumors are microadenomas than macroadenomas. Earlier, they were wondering if OCP use contributed to some fluctuations in prolactin levels. We don't have very convincing evidence to prove so. And in men, tumors are usually larger, and galactorrhea is uncommon in men unless it's a very large mass, because you need both estrogen and prolactin to lactate. So men do not have estrogen levels high enough that can cause galactorrhea, although you do see it in some people. In fact, the first person I saw here on an endocrine consult, that was my first day as an attending, and he had galactorrhea. And when I was examining, he squeezes it and it's all over my coat. So it can be that dramatic. And yeah, he was very obese, yes. And he still comes to my clinic. Some of you may have seen him if you had rotated with me, but all of his symptoms have gotten much better now. And yeah, so the reason it decreases sex steroids is because of the effect of prolactin on your hypothalamus. It decreases GnRH secretion, so that subsequently decreases, your sex steroids, leading to hypogonadism and osteoporosis. Medical treatment of prolactinoma is by two major drugs which are FDA approved, cabergoline and bromocriptine, very commonly used in medical practice. And these are dopamine receptor agonists. Remember, dopamine is the prolactin inhibitory hormone. So these are dopamine agonists to decrease prolactin levels. So they decrease prolactin mRNA synthesis. So they thereby decrease the content and secretion, decrease the growth rate, decrease size of the tumor. So side effects with these medications is usually because of the dopamine agonistic activity, which can cause mood changes, anger issues. Some patients might report hypersexuality, and it can be quite difficult to tolerate. So it's good to increase your dose gradually and also tell the patients about all these expected side effects. Again, nausea, dizziness, and it can also it's known to cause heart valve abnormalities at higher doses. So low doses used in the treatment of prolactinoma usually should not cause it, but this is typically seen in people who are treated with cabergoline for Parkinson's. So when you want to give patients a higher dose of cabergoline, then we do get a transthoracic echo to confirm that the valves are all right, and only then proceed with it. So cabergoline is the preferred agent just because of the ease of administration. It's twice a week and it has a better safety profile. However, during pregnancy, we prefer bromocriptine than cabergoline. And the dose typically 0.25 milligrams twice a week, and then we titrate. We start at the lowest dose. So when somebody has a very large tumor, it's not good to start a higher dose because that's not the way we do it, because we don't want the tumor to very rapidly shrink in size as well, as opposed to somebody with hyperthyroidism who gets treated with high doses of methimazole when they're present. This is not similar to that. So treatment of prolactinoma. So if it's a microadenoma, we treat them with medications, adjust doses to keep the prolactin levels lower than a 50. And then we adjust medicines accordingly and follow them up, say once in 6 months to once a year. But at the time of diagnosis, when you start somebody on cabergoline, you want to bring them back in 1 month, check the levels, go up on the dose, see them at least once every 3 months for the first year or so. And if there is any intolerance to drugs, then you could change the drug. You could switch between bromocriptine and cabergoline. And if that does not work too, then you might have to consider surgery. And if it is a macroadenoma, they always need a formal visual field testing and referral to ophthalmology, and they will need a pituitary MRI. So again, the treatment for macroadenoma as well is by cabergoline, but you have to do an MRI sooner than you would do in a microadenoma. Make sure the tumor shrinks in size. So if there is shrinkage, then continue what you would do for a microadenoma. But if the tumor does not shrink in size, if it's resistant, prolactin levels are still elevated, then you would refer them for surgery. So this is the only pituitary tumor which is secretory that is managed medically and not surgically. So moving on to the next case. So we have a 45-year-old female with history of hypertension presented to the ER with persistent left-sided headache. Her blood pressure was 140/110, but was not compliant with her home medicines. The CT of the brain was done, showed a stellar mass, and an MRI subsequently revealed a 2.2 centimeter intracellular mass with supracellular extension. And then she was seen in clinic later on, and then she said that she began to snore several years ago. The space between her top incisors widened, sorry, it's a spelling mistake, and her hypertension became more difficult to control. she denied hirsutism and increased sweating or enlargement of hands and feet. She had a thyroidectomy done about 4 years ago due to a nodular goiter. Her blood pressure was 156/108. But she was noted to have larger hands than what you normally would, but no other abnormal physical findings were noted. So lab tests were done, showed a cortisol of 10.9 micrograms per deciliter, which is essentially normal. Free T4 was 0.8 nanograms per deciliter, prolactin 10.9, estradiol 105, growth hormone level 8.2, which is significantly elevated than normal, IGF-1 of 648 nanograms per ml. Which of the following is the most appropriate next step in the evaluation of this patient? An inferior petrocell sinus sampling for growth hormone, measurement of growth hormone after an oral glucose load, referral to neurosurgery, measure growth hormone after insulin-induced hypoglycemia. Any takers? Yes, that's correct. Very good. It is referral to neurosurgery because this person very clearly has classic symptoms of acromegaly, and she also has an IGF-1 level that is way beyond the upper limit of normal, and so does the growth hormone level. So there's really no need for us to do other endocrine tests here, and we can directly refer her to a neurosurgeon. However, if there is a discrepancy, then we would do a confirmatory test like an oral glucose tolerance test, which we'll talk about. So some of the facial features in patients with acromegaly, they have very coarse facial features like widening of the nose. They'll have prognathism, widened jaw, space between incisors will widen, tongue will get bigger, macrognathia. So this is a very insidious disease. So people may not notice it. And normally it gets diagnosed 10 to 12 years after they have the condition. And that's why they present with such large pituitary tumors, which make it more complicated. And so they'll have enlarged hands and feet. Important to ask about changes in ring and shoe size. So how do you diagnose biochemically somebody with acromegaly? Never measure growth hormone because it's very pulsatile. It is not a good test to do. What we need to do, and I will show that to you based on the study here. So they looked at growth hormone levels in 4 separate individuals, a young female, male, and older people. So normal growth hormone, remember what we talked about, it's anything less than 1 micrograms per liter or nanograms per ml. So just in a normal individual without acromegaly, you see how high the growth hormone levels are over a span of 24 hours. And it's actually a whopping close to 50 here, which is way beyond normal. And this can result in people getting falsely diagnosed with question acromegaly. And I see such patients in my clinic with elevated growth hormone levels and normal IGF-1 levels, and I discharge them from my practice because they don't need to be seeing me. So never do a growth hormone level. It's very pulsatile. So you would also see the same in this young male. He has much higher levels, and even older individuals do have increased levels during certain times, although the effect is not as dramatic as young people, just because with physiology and aging, your growth hormone levels normally decline. But in females, the effect of estrogen also will induce growth hormone secretion, so the levels are quite dramatic. So bottom line, never do growth hormone levels, but it's done for confirmatory testing and in post-operative management of acromegaly. So we need to measure serum IGF-1 instead. So what is IGF-1? So this, does anybody know? So this is an insulin-like growth factor 1, and this is primarily synthesized in the liver. So this has a molecular structure similar to insulin, and this is an anabolic protein. So the synthesis of IGF-1 is favored or induced by the effect of growth hormone. Because IGF-1 has a longer half-life, is not pulsatile, it's a better test to do, and it's a better indicator of measurement of hormones to document or diagnose acromegaly. And confirmatory test is done in some people who may not have the characteristic lab values that we want to see. So we give them glucose load in the morning, 75 grams, similar to an OGTT, and then check the growth hormone levels and glucose levels at the time of the test, which is fasting at 8 a.m. And then check another 1 hour later and another level 2 hours later. So what you want to see is decrease in growth hormone levels, and it has to fall below 1 nanograms per mil. But in patients with acromegaly, it usually will be in the 4 to 5 range or more than that. Nowadays, with better assays, the cutoff has even been brought down to say 0.4 micrograms per liter of growth hormone. So we do have some cutoffs, and this is also very important in the post-operative period where we monitor patients to see if they are in remission or not. So signs and symptoms in acromegaly. So this was done in a large group of patients, and most of them will present with coarse facial features, acral growth, large hands and feet, change in ring and shoe size, and less common but still present headaches because of the size of tumors. Remember, it's mostly going to be a macroadenoma, erectile dysfunction. There's a characteristic arthritis that they all have because of the tissue swelling, and fatigue, neuropathy, and depression. They'll have carpal tunnel syndromes, again because of the swelling, daytime somnolence, probably because of the increased incidence of sleep apnea, and hirsutism, galactorrhea, and so forth. So what is the treatment options for acromegaly? We need to do a pituitary surgery. That should be your first treatment of choice. It's a transphenoidal pituitary surgery. It's usually done endoscopically, sometimes microscopically, according to the neurosurgeon's preference. And that will be the treatment of choice. And after treatment, if they are not in complete remission or if the tumor is not amenable to surgery, we can consider medical treatment as well. So the drugs we use are somatostatin receptor analogs like octreotide, lanreotide. The newer one is pasireotide, and these will inhibit the growth hormone secretion. And another class of drug, this is newer, much more expensive, but slightly better in terms of efficacy. It's called pegvisomant, and this blocks the growth hormone receptor. And the next option is to radiate the pituitary. This can be considered in older people because hypopituitarism is an expected side effect from it, and they will need hormone replacement for the rest of their lives. So achieving surgical remission with tumors like acromegaly, Cushing syndrome, this has to be monitored closely in the postoperative setting. And when it comes to acromegaly, this was a study that was done to look to see what the rates of remission were. And if microadenomas had a much higher range of remission compared to macroadenomas. So the rate of remission after surgery was 75% in microadenomas and only 10% in macroadenomas, which means they persisted to have the condition later. So how we diagnose if the person has been cured or not is again by the glucose tolerance test. We need the growth hormone level to go less than 1 or 0.4. This was a much older study, and that's why they say it's 2.5, but things have changed now. And it's important to address the morbidity and mortality in people with acromegaly because of the predominantly increased incidence of cardiovascular disease that we see here. So acromegaly gets diagnosed by cardiologists. So it's important to know about the features of this condition. This is very, very rarely diagnosed by endocrinologists, mostly primary care providers, ophthalmologists, dentists, cardiologists, and so forth. So knowledge about this condition is important. And probably there's an increased risk of cardiovascular disease because of increased incidence of diabetes and hypertension. And they're prone to OSA, thereby have respiratory disorders, arthritis, because growth hormone IGF-1 favors any form of growth, increased incidence of colon polyps. So anybody with acromegaly, irrespective of the age of diagnosis, needs to get a colonoscopy screen and further colonoscopies as per what was seen on the initial test. And increased incidence of thyroid nodules too. So you will often have these patients presenting to you with thyroid nodules, or they'll already have a thyroidectomy done by someone previously. And also they do have more incidences of fibroids too, but that's a very common condition. So it's hard to say if it's just due to acromegaly or not, which is much rarer. So now that we have talked about acromegaly, we'll go on to the next case here. So this is a trick question, but I need a show of hands for this one. So a 46-year-old woman with complaints of fatigue, weakness, irregular menses, and acne for 18 months. She was found to have osteopenia with a DEXA bone mineral density of -2.1 in the lumbar spine. No significant past medical history. She was 64 inches tall and weighed 130 pounds. And blood pressure was 145/90, just a little bit elevated. She had facial rubor, proximal muscle weakness, and atrophy. The 24-hour urine-free cortisol excretion was 52 micrograms per deciliter. Normal is anything less than, say, 58. So this is on the upper limit of normal. Baseline serum cortisol was 18. And after 1 milligram dexamethasone suppression test, it was 17. The baseline plasma level of ACTH was low at 8. So what does this patient have? She has Cushing's syndrome. So what is the most likely disorder causing Cushing's syndrome in this woman? What is the most likely site of the disorder? Sorry. The pituitary, pancreas, C, hypothalamus, D, adrenal cortex, E, lung. How many people think it's the pituitary? Okay, how many people think it's the pancreas? Hypothalamus, adrenal cortex? Good, yes. So the clue here is she had a DEX suppression and AM cortisol was not suppressed at 17. So that diagnoses you with Cushing's. And your ACTH is low at 8, which means it's not a pituitary mediated cause. So that makes it a Cushing's syndrome due to your adrenal cortex. So this will tell you about the discrepancies we face with measuring urinary free cortisol. And this is why it's never a good idea to do it as the first test to diagnose somebody with Cushing's, because as you see here, green is normal individuals. Green is normal individuals and black denotes people with Cushing's. Many people with Cushing's have normal free urinary cortisol levels. Very few have elevated levels. So it's important to see how high the levels are, whether it is high normal or low normal, and then decide. Because for example, I have a patient in the hospital right now with Cushing's disease that Natasha and I are seeing, and she did have a non-suppressed AM cortisol of 25, which was so high. And her salivary cortisol was also elevated, but urine-free cortisol was normal until the end, and it was not more than 15. So you could see such values, and that should not make you think that this person does not have Cushing's. And ACTH levels, of course, because it's an adrenal-mediated cause, it is much more elevated when compared to normal individuals. So features, clinical features in patients with Cushing's, it's kind of striking. And these features are more pronounced in people with pituitary disorders than in adrenal causes. Adrenal Cushing's can be very subtle. There's many cases of subclinical adrenal Cushing's that we do not even diagnose. But pituitary Cushing's, if you see the patient, you will normally know it. So again, you know, the characteristic moon-like faces, facial puffiness, supraclavicular fat, and the buffalo hump, although it's hard to differentiate that from some obese individuals as well. So the striae in Cushing's is different from the normal striae that we see in, you know, post-pregnancy, because it's very thick and violaceal, and it's almost got a purplish hue. So that we call as pathological striae. But remember, for people to develop striae, again, it will take time and it will take many years. So in early stages, they may not have striae. So not having striae does not exclude Cushing's. Again, easy bruising. So what's the difference between Cushing's disease and Cushing's syndrome? This is something very basic, which many people may not be aware of. So Cushing's syndrome denotes excess cortisol. It could be from the adrenal, it could be from the pituitary, it could be from an ectopic source. But Cushing's disease indicates a cortisol excess due to the pituitary alone. So usually an ACTH secreting pituitary adenoma, we call it Cushing's disease. So I'll briefly go into diagnosis of Cushing's. So the most common cause of Cushing's syndrome, we're not talking about pituitary causes here, but in general is iatrogenic. So always look at their med list, look to see if they're on steroids and determine if that could be the cause of cause of cortisol excess. So when in suspicion, perform one of these screening tests. It could either be an overnight 1 milligram dex suppression or a midnight salivary cortisol level. You need at least 2 samples for that, and urinary free cortisol, one of the 3. If it is normal, you leave it at that. If it is abnormal, then you have to do all 3. And then you diagnose Cushing's if at least 2 out of the 3 diagnostic tests are positive. And then you probably will have to refer them to endocrine. So the clue to Cushing's disease versus an adrenal or ectopic versus an adrenal cause is, again, an elevated ACTH, which is important and should not be missed. So when you know it's Cushing's disease, then you do an MRI of the brain. That should be your first step. Usually they will have a pituitary adenoma. If it's larger than 7 millimeter, then we may not need many additional investigations, but it's always good to check a CT chest, abdomen, and pelvis also to rule out ectopic causes, because although it's very rare, it's still a possibility. Could happen from lung, your thymus, pancreas. So you have to scan your other organs as well. And when there is no evidence of tumor, both in the pituitary and in the peripheries, then it becomes complicated. Or if the brain mass shows a mass less than 6 millimeter or if you have a pituitary adenoma and an chest mass, then we need to do what is called as inferior petrocell sinus sampling. So this is a complicated procedure which is done either by some trained interventional radiologists or neurosurgeons. They check the levels of ACTH in the pituitary as well as in the periphery. So you have to catheterize your pituitary vessels for this, and then they measure and plot a ratio of ACTH from central to periphery. So if the central ACTH ratio is more than 3:1, then it diagnoses you with a pituitary cause. Whereas if the peripheral ratio is higher than the central ACTH, then this person likely has an ectopic. So this will be another investigation that is done. So once we've diagnosed somebody with Cushing's disease, how do we treat them? Again, the treatment is surgery. So transsphenoidal pituitary resection, and post-operatively, it's very important for these patients to be on glucocorticoids. Remember, they were exposed to such high doses of corticosteroids that after you take the pituitary adenoma or an adrenal tumor, the body will no longer have the cortisol excess, so they'll crash. So you have to supplement them with steroids in the post-operative period. That's the most important thing. And then gradually wean them over. It may take many days for the HPA axis to recover. Sometimes it may not recover too. It may take any time between a few months to as long as a year, or probably even longer than that sometimes. And there is medical therapy as well for Cushing's, but not very widely used because of the long-term usage that will be required, and also the cost. And we could consider radiation in resistant tumors or recurrences. And finally, the last resort should be bilateral adrenalectomy in very severe resistant cases. So coming to the next case, we have a 65-year-old male who has been treated with testosterone for 5 years, but chose to stop treatment 4 months ago. He's seen by you because of increasing fatigue and a brief disease spell with numbness of his extremities. BMI is just a little elevated at 31, but otherwise physical exam is not is normal. And his lab tests show a low testosterone level and IGF-1. FSH was slightly elevated at 20.5, LH 2.4. CT of the head shows a 2.1 centimeter mass that appears to arise from the sella. What is the most appropriate next step in his management? So this is a person who was on testosterone from some time, had hypogonadism, treatment was stopped, subsequently had dizziness, was noted to have a sellar mass. He has low testosterone and other hormones are also noted to be deficient, low IGF-1, low LH. And so what's the next step? Refer to a neurosurgeon, order an MRI, resume testosterone treatment, perform a cortisol stimulation test, begin octreotide. We'll come to the answer later. So this talks about the prevalence of pituitary adenomas. So as we talked about earlier, predominantly or the most common type of pituitary tumors that are secretory are prolactinomas, which is 30%. Closely followed by that is what's called as a null cell adenoma, which means it does not synthesize any specific hormone when we stain it with immunochemistry at the time of surgery. And we do see what is called as gonadotroph adenomas, which also are fairly quite common, almost in 22% of the patients. And they secrete an increased FSH, there's increased LH secretion. However, these will also be asymptomatic because you can't really be hypergonadal. You can't have more menstrual periods than you could potentially have. So these patients will also have very subtle symptoms, maybe hypogonadism because of increased gonadotropins down the line, but this will just look like a non-secretory adenoma to you. And then again, you get some patients with acromegaly and Cushing's syndrome, and TSH secreting adenomas, very, very rare. So when you look at it, almost 50% of the pituitary adenomas are not secretory. So you cannot always expect them to have some kind of clinical manifestations. Most likely, we will not see them. And this talks about age at diagnosis of tumors. So the null cell adenoma, gonadotropin adenomas, they are more common in the elderly population. So prolactinomas, as you see, is more common in young people. Acromegaly and Cushing's disease is kind of seen diffusely across the board. So there's no specific time frame which will highlight the age at diagnosis. So gonadotroph adenomas, they could be clinically silent. And if they have a big old mass there, they will have headaches, visual complaints, and hypopituitarism. And again, increased hormone levels, increased FSH or LH. And the treatment again is with surgery or radiotherapy if it's a macroadenoma. It's important to know the clinical features of hypopituitarism. So it's important to ask your patients what symptoms they have and put together everything and see if this could be due to a pituitary cause. Because if it is yes to everything across the board, which we will see in people who don't have any issues as well, but that should definitely prompt you to evaluate further. So hypocortisolemia, again, fatigue, lightheadedness, dizziness, weight loss, irregular periods, electrolyte abnormalities, hyponatremia, hypoglycemia, hypothyroidism, they'll have fatigue again, weight gain, constipation, loss of hair, dry skin, hypogonadism, low libido, ED, and osteoporosis. And in young people, puberty may be delayed, but in older people, you might see loss of hair in the body and decreased shaving times for men and decreased body hair. And these are subtle findings. Even if you look at somebody who comes to you with hypogonadism, it's important to ask the person if they've noticed decrease in their facial and body hair as well. And growth hormone deficiency, the signs of this in adults is subtle. You will notice an increased ratio of fat mass over muscle mass, which can be very subtle, but overall they will report decreased strength, overall fatigue, and commonly you will also have osteopenia. So coming back to the Cortrosyn stimulation test that we had talked about earlier, I know we discussed this during our lecture on adrenal disorders, but I'll just go over it quickly. In any person, if the morning cortisol is more than 10, very, very less likely for you to have adrenal insufficiency. But if it is lower than 10, yes, it is possible, it is likely. The cutoff can be 10, or if you want to be on the safe side, you can even do 15. So that depends. And we have different people who prefer different cutoffs. And in those with, primary adrenal insufficiency, corticotropin will not increase your cortisol levels. The curve will be flat because your adrenals are not working. And giving corticotropin, which is synthetic ACTH, is not going to influence your adrenals to make more cortisol. However, in somebody with secondary adrenal insufficiency, yes, you start out with baseline low cortisol levels, but you give them corticotropin, you will see an increase with increase in cortisol over time. This is because these people do not have ACTH to begin with. So if you give them ACTH externally, that's definitely going to increase your cortisol levels. However, in states of chronic ACTH deficiency, your adrenals are also stunted. So the adrenal reserve is diminished. And so the adrenals are not as robust in their response as would be a normal person's. So that's why you see the stunted response in secondary adrenal insufficiency. However, you will still see a response there. And in normal individuals, they will respond very well once you give the corticotropin. So the cutoff we see here is usually 18. If it's anything over 18 after a Cortrosyn stimulation test, chances of them having adrenal insufficiency is very less likely. So how do you manage non-functional pituitary tumors or, gonadotroph adenomas, null cell adenomas? Always get an MRI. Probably that's how they get diagnosed with pituitary tumors in the first place, but it's important to have an MRI on file. And we also have to exclude other causes to the headaches, whether it could be some other neurosurgical pathology that's causing it. And if it is a microadenoma, do pituitary hormone tests, and if they're normal, just observe them. So repeat an MRI for somebody with a microadenoma to document it's not getting bigger. The next MRI should be in 1 year. If it's somebody with a macroadenoma, then you have to be more diligent with follow-up. Next MRI can be in 6 months. If they have secretory adenoma with concern for rapid growth, then you can even do it as early as 3 months, or if you want to monitor therapy, earlier MRIs can also be done, but macroadenoma, typically we follow them up more closely. And people with macroadenoma always need visual field testing and referral to ophthalmology. And the treatment is surgery for macroadenoma, even if they do not have any hormone deficiencies. So coming back to the case that we discussed earlier, so the thing that we needed to do on him is a Cortrosyn stimulation test, because this is somebody who is symptomatic with hypopituitarism with a cellular mass. He presents with dizziness, so he definitely needs neurosurgery. But prior to surgical referral, we have to make sure that he's supplemented adequately with hormones that he lacks. So he has not been checked for adrenal insufficiency. So we need to do a Cortrosyn stimulation test, start him on steroids appropriately prior to the referral, and that will also improve your surgical outcomes. So causes of hypopituitarism, it could be, it's most commonly due to tumors, pituitary tumors, and surgery for pituitary tumors. But tumors could be even in the suprasellar areas, like your craniopharyngiomas, sometimes Rathke cleft cysts. They can also present with hypopit. Autoimmune hypophysitis, like lymphocytic hypophysitis, which we will talk about. And nowadays, drugs. So cancer immunotherapy, we have CTLA-4 inhibitors like pembrolizumab. I'm not sure if you're familiar with it. So all these drugs are being used more and more often for treatment because they have very good outcomes in cancer patients. They unfortunately also affect your normal endocrine cells. So there's a more increased incidence of finding people with hypopituitarism, adrenal insufficiency, type 1 diabetes because of their, immune mediated side effects. So we do see those patients presenting with hypophysitis and hypopit, but that's in the more recent times. And pituitary hemorrhage, trauma, aneurysms and infections, granulomatous diseases, Wegener's, TB, sarcoid infections, they can all cause hypopituitarism. And we discussed clinical features earlier. So coming to lymphocytic hypophysitis, it's one of the very interesting causes of hypopituitarism. This is an inflammation of your pituitary, and it will present as a patient probably nearing term or just in the postpartum period. They'll present with headaches, visual disturbances, and then they will be noted to have an enlarged pituitary on MRI. So this is more common in women than men. The ratio is approximately 6:1. And it's also more in people who have another autoimmune condition. Mostly it's Hashimoto's. And the presentation we talked about, and they can also present with hormone deficiencies, especially ACTH. So if it is somebody in the peripartum period, we need to check their cortisol levels, ACTH levels, and give them adequate steroids to cover for the rest of the pregnancy and even later. So it's tricky because although we could do an MRI with GAD in pregnancy, we do avoid it. So we typically do an MRI without GAD, or even avoid the MRI if possible, if symptoms are subtle, but normally they'll have an MRI without GAD. And we just observe. We normally do not do a surgery because it will improve with time. But if they have visual field defects, severe headaches, then surgery can be done, although it's a very tricky decision. Coming to Sheehan syndrome, less commonly seen these days, but it's more common in the developing world. Typically seen after delivery in a lady with severe postpartum hemorrhage. This is because there is a hemorrhage into the pituitary, and pituitary necrosis occurs following that. And that will make you have hypopituitarism down the line. Immediate symptom you will notice in these people is failure to lactate. Unfortunately, there's no treatment for that, and that's what will bring people to medical attention. And then they will later on develop irregular menses, they might develop hypocortisolemia, secondary adrenal deficiency. So following them up is important, and they will need hormone replacement. And over time, they can also present with what we call as empty sella on MRI. And sometimes people with Sheehan syndrome may not even have symptoms in the postoperative period. They could come to your clinic 5 or 6 years down the line with symptoms of hypopit. So it's important to ask a history about, prolonged labor with excessive bleeding. That can also give you a clue. So this is an example of a tumor that bled into the cavernous sinus. Remember, cavernous sinus is lateral to the pituitary. So if there's a lateral expansion and bleeding into the cavernous sinus, patients can present with nerve palsies according to the nerve that is compressed upon. So he has abduction of his eyes and also ptosis. So this is an MRI showing an image of a pituitary hemorrhage. So pituitary hemorrhage is, as the name says, bleeding into the pituitary, and it's a neurosurgical emergency. So what's the difference between hemorrhage and apoplexy? Not every hemorrhage needs to be apoplexy. So we call it apoplexy only when you have the syndrome that is associated as a consequence of you having a hemorrhage, which is sudden headaches, visual field problems, altered mentation, probably low hormones. So all this together called is apoplexy. For example, this person over here, he has a very small pituitary hemorrhage. His chiasm is intact. He's very unlikely to have had dramatic symptoms at the time of presentation. And so we cannot say that he has apoplexy. So hemorrhage mostly occurs in patients who have pre-existing pituitary tumors, those on blood thinners, and it's also commonly seen in pregnancy. And surgical intervention is often needed for pituitary hemorrhage. So I think this is the last slide. Yeah. So common causes of intracellular mass, again, hypophysitis, immunotherapy and drugs, sarcoidosis, Wegener's. Sometimes you can have a big old pituitary cyst there causing problems, infections. There's another interesting condition called Langerhans cell histiocytosis, which can present with a mass and hypopituitarism. And those patients usually have diabetes insipidus as well, lymphomas. Always think of Mets to pituitary if it's somebody who has a history of cancer, commonly lung, breast, renal cell carcinoma. So that's something, and melanoma as well. So you have to keep an eye out for that. And how do you treat hypopituitarism? Again, assess the hormonal axis and replace hormones. Usually hydrocortisone and twice daily dosing works, and prednisone usually once a day dosing. Remember, adrenal insufficiency, which is secondary, does not need replacement with fludrocortisone because your mineralocorticoid axis is intact. And levothyroxine, sex steroids, estrogen, progesterones. In people who develop hypopituitarism, remember they're not infertile if it happens in young people. So they can be given gonadotropins to conceive. If you've rotated with me in the clinic, you'll see young men who have hypogonadism on clomiphene or instead of testosterone for the same reason. And again, growth hormone replacement, it's advised, but because of the cost, practically it's not being done as much as it should be because it's a very expensive medicine to be on. And yeah, so I think we have come to the end of the lecture. And any questions? No. All right. Thanks for your attention. Yes, hello.
I don't know if you remember, like the first week of July, we had a patient, a female, like pregnant patient with left visual deficit, and she went to SIDH.
Oh, yes, I think I should end this lecture. Sorry. End. Okay, sorry.